who are with us in this conference room, as well as those of you who are watching us on the live streamlining as well. This is a periodic press conference on the subject of COVID-19, what the Japanese government has been doing, and all the other related questions to be asked through the conference as well. Today we have two experts who've been heavily involved in the policy, decision-making, as well as the actions that have been taken by the Japanese government. And they work day in, day out with the government as well. And there could be no other persons who I could think of as being knowledgeable about the situation in Japan regarding COVID-19 as well. On my right, I have speakers, including these two experts. The first would be Dr. OMI Shigeru Omi, who is the chairman of the COVID-19 Advisory Committee on Basic Action Policies of the government. He's also the regional director emeritus of World Health Organization, as well as the president of the Japanese Community Healthcare Organization. Further to the right is Mr. OSHITANI, Hitoshi, Professor Hitoshi OSHITANI, who is the professor at the Department of Virology, Tohoku University Graduate School of Medicine. He's also a member of the Novel Coronavirus Expert Meeting, New Coronavirus Infectious Disease Control Headquarters, and member of the COVID-19 Advisory Committee on Basic Action Policies and COVID-19 Cluster Response Task Force. He's also a member of that task force at the Ministry of Health, Labor, and Welfare. To my right, I also have Mr. Uyama, Tomochika Uyama, who's the Director General, Office for Coronavirus Disease 2019 Preparedness and Response. We also have Mr. Masaaki Iizuka of the Ministry of Finance joining us as well. He is the Director for Fiscal Affairs Budget Bureau, who should be able to inform you about the supplementary budget that has just been decided by the Japanese government. Further to the right, depending on the questions, we have a couple of more people from the Ministry of Health, Labor, and Welfare as well. You may already be familiar with them. Mr. Kazuo Taguchi, Director of the Office of Global Health Cooperation International Affairs Division of the ministry, as well as Mr. Hiroshi Umeda, Director for Infectious Disease Information Surveillance Office, Health Service Bureau at the same ministry as well. My name is Masato Otaka. I'm the Press Secretary at the Ministry of Foreign Affairs, and I will be moderating the event today. And I will also be taking questions from those of you at the conference room, as well as those of you viewing this conference online as well. So without further ado, I would like to invite Dr. Omi to give his opening remarks.
Thank you. First of all, I'd like to thank you for giving us this opportunity to speak to journalists worldwide. Now, given the time limitation, I'll start with this presentation. First, let me start with the COVID-19 in Japan. Relative to the United States and Europe, the number of infections and deaths in Japan has been small. At the same time, the number of deaths in many other parts of East Asia has also been low. Taiwan in particular has succeeded in keeping the number of fatal cases to a minimum. Now, why has the number of COVID-19 cases and deaths been comparatively low in Japan? A number of reasons have been suggested for Japan's relatively small number of infections and deaths. The most widely discussed include the following three. First, easy access to medical care. Secondly, generally high quality of medical care in even rural areas. And thirdly, Japanese public's high standard of hygiene, willingness to comply with government requests, and other cultural trait and lifestyle habit. At the same time, two important factors have not received due attention. They are early detection of transmission waves, and secondly, cluster-based approach. I'll explain a bit further later. Now, Japan detected first wave of COVID-19 infections from China at an early stage, leading to a more gradual transmission curve that allowed Japan to delay the peak of the outbreak and to buy time to prepare. The US and Europe, by contrast, suffered rapid early surges. The graph compares infections in Japan and Germany. Germany is the orange bar graph, and Japan is the blue one. You can see the Japanese number are very small, very low. We have also added a second line, that is dotted line, for Japan at an exaggerated 10 times scale to make it easier to compare. That's the dotted line. You can see that peak of the outbreak came later in Japan than in Germany. The lower graph is a close-up of the early stages of the outbreak. You can see that Japan had confirmed cases before Germany did, but its increase was more gradual. So this means that COVID-19 was detected earlier in Japan and spread less rapidly. The same pattern is seen in other countries, including Italy, so I'll not go into detail. Now, let us discuss what we call Japan's cluster-based approach. At an early stage of the outbreak, Japanese public health experts identified the virus's characteristic mode of transmission. For influenza, left side, one infected person infects one or more people, the black one. Then, now for the COVID-19, that's the right side. Regardless of illness severity, 4 out of 5 infected people, indicated with the black box, 4 out of 5 infected people do not infect anyone else. And only 1 in 5 infects someone else. And an even smaller minority infects multiple people, that is a red one, leading to the formation of what we call clusters. Now, COVID-19 spread by forming clusters. Preventing clusters, especially in the early phase of an outbreak, can result in suppression of the outbreak or virus. Now, when it comes to epidemiological investigations, most of the other countries adopted what we call prospective tracing. Now, in this prospective tracing, the right side, beginning with newly confirmed cases, that is red and black. Beginning with newly confirmed cases, close contact, that is pale red. Close contacts are identified and monitored for symptoms, whether developed symptoms or not. This method was used in the time of SARS outbreak. That was 2003.
Excuse me, Dr. Omi. Sorry. There's been some technical hiccup. So can we stop the the explanation for a minute or two.
So I suspend?
Yes, just for now.
Suspend.
Yes, before it can be reconnected. I think we're ready to resume or maybe restart, and we apologize for the technical hiccup. In any case, I would just like to remind you that we have sent some handouts to those of you who are watching us on live streaming. And Dr. Omi was actually making his remarks in line with the light green handout. That should be in front of you as well. So I would like to resume this session from the beginning of Dr. Omi's presentation once again.
Thank you very much for this opportunity. Now, let me start with the COVID-19 in Japan. Relative to the United States and Europe, the number of infections and deaths in Japan has been small. At the same time, the number of deaths in many other parts of East Asia has also been low. Taiwan, in particular, has succeeded in keeping the number of fatal cases to a minimum. Now, why has the number of COVID-19 cases and deaths been comparatively low in Japan? A number of reasons have been suggested for Japan's relatively small number of infections and deaths. The most widely discussed includes 3 reasons. Number 1, easy access to medical care. Secondly, generally high quality of medical care, even in rural areas. Thirdly, the Japanese public's high standard of hygiene, willingness to comply with governmental requests and other cultural trait and lifestyle habits. At the same time, 2 other important factors have not received due attention. They are, firstly, early detection of transmission waves, and secondly, cluster-based approach. Japan detected first wave of COVID-19 infections from China at an early stage, leading to a more gradual transmission curve that allowed Japan to delay the peak of the outbreak and to buy time to prepare. The US and Europe, by contrast, suffered rapid early surges. The graph below compares infections in Japan and Germany. Germany is the orange bar graph, and Japan is the blue one. You can see the Japanese numbers are very low. We have also added a second line, that is dotted line, for Japan at an exaggerated 10 times scale to make it easier to compare. That dotted line, you can see the peak of the outbreak came later in Japan than in Germany. The lower graph is a close-up of the early stages of the outbreak. You can see that Japan had confirmed cases before Germany did, but its increase was more gradual. So this means that COVID-19 was detected earlier in Japan and spread less rapidly. Now, same pattern is observed in Italy and other countries. Now, let us discuss what we call Japan's cluster-based approach. At early stage of the outbreak, Japanese public health experts identified the virus characteristic mode of transmission. For influenza, that's the left side. For regular influenza, one infected person infect one or more people. Now, when it comes to COVID-19, regardless of illness severity, 4 out of 5 infected people. That is the black one. 4 out of 5 infected the people do not infect anyone else. 4 out of 5 do not infect anyone else. Only 1 in 5 infect someone else, and even smaller minority infect multiple people. That is a red one, leading to the formation of clusters. COVID-19 spread by forming clusters. Preventing clusters, especially in the early phase of an outbreak, can result in suppression of the virus. Now, when it comes to epidemiological investigations, most of other countries adopted what we call prospective tracing. Prospect tracing, we're beginning with newly confirmed cases. This is a black and red. Beginning with the newly confirmed cases, close contact, that is pale red. Close contacts are identified and monitored for symptoms to see whether they develop symptoms or not. This method was used in the time of SARS, the year 2003. Now, Japan's retrospective tracing. In this tracing, in addition to prospective tracing, past activities of multiple infected people, that is black. Past activities of multiple infected people are investigated in order to identify common sources of infection. That is a gray, round gray. And contacts associated with those sources are then monitored closely to prevent further spread. The cluster-based approach uses thorough retrospective contact tracing to identify common sources of infection, which helps suppress further spread of the disease. Retrospective tracing can identify infections more efficiently than a strictly prospective approach, enabling more effective control. Now, let's move to 3 C's. Based on analysis of the shared characteristics of clusters, Japan developed a concept called the 3 C's to denote high-risk places and situations, namely closed spaces, crowded places, and close contact settings. The public was asked to avoid the 3 C's, and awareness of that term became quite widespread. The concept has been expanded to 3 C's plus, which includes behaviors such as loud talking and singing. Now, with regard to the state of emergency, a monitoring system using indicators such as the effective reproduction number had been put in place to detect early signs of a surge in infections. A state of emergency was declared on 7th of April, mainly for 3 reasons. First one, early signs of a surge in infections were detected through close monitoring. Secondly, strains on the healthcare system was growing. And thirdly, cluster-based approach was reaching its limit. Public cooperation was vital, and effective reproduction number remained below 1 during the state of emergency. Now, with regard to the testing in Japan, compared with other countries, Japan has performed fewer PCR tests for the virus. Its testing has focused on high-risk groups and the people associated with the suspected clusters, including close contact. At the peak of the outbreak in early April, timely testing was not always available and possible to those who need it due to limited capacity. This was an issue that Japan is now addressing. Despite such issues, Japan's testing overall infrastructure has been adequate from a public health perspective point of view. Japan's testing has been appropriate to the scale of the outbreak. It has conducted more tests per infection and per death, more tests per infection and per death than many other countries. But with the exception of the peak period of the outbreak, the percentage of the positive result has been lower than in other countries. Low positive rate are an indicator of sufficient testing according to the World Health Organization. Now, testing going forward. Japan eases restrictions and seeks to resume social and economic activities while preparing for possible new outbreaks. The following goals should be considered in testing policy. There are three, but I'll emphasize on the last one. Use of antigen detecting rapid diagnostic tests, RDTs. RDTs are less sensitive than PCR, but they're quicker, easier, and can identify high viral load, which may help detect especially infectious cases. RDTs could be particularly useful for preventing outbreaks in hospitals, nursing homes, and other high-risk settings. Now, conclusions. Citizens' cooperation has been vital to slowing the spread of the virus while preventing the healthcare system from becoming overwhelmed. A focused, clustered-based approach and avoidance of the 3 C's helped control the spread of COVID-19, especially in the early stage of the outbreak. Of course, this is no time for complacency. Latent transmission change can surface at any time, and new types of clusters could develop in the future. The decline in the number of new cases should be taken as an opportunity to prepare for a potential next wave. Japan has learned a lot, and while there is still much to understand and learn, it should share its experiences with the international community and actively participate in the global pandemic response. Thank you for your attention.
Thank you, Dr. Omi. Now I would like to invite Mr. Iijima of the Ministry of Finance to make his opening remarks.
Allow me to speak in Japanese. I would like to give explanation regarding the second supplementary budget. The basic concept for putting together the supplementary budget, as the end of May, the emergency declaration was lifted, and people will restart economic activity going forward. In order to bring back normalcy, it will take considerable time. Therefore, under the current situation, we are going to support the businesses in order to maintain employment and business activities. However, we also have to prepare for the next waves. Under the guidance of Prime Minister the other day, we put together the first supplementary budget amounting to 117 trillion yen based on the recommendation appropriation by governing parties, we put together a second budget. We have 4 major points in this second budget. First of all, we are going to support fixed expenses, including human labor cost and rents. First of all, we are going to increase the employment adjustment subsidy up to 15,000 yen. And in this way, we are going to enhance employment adjustment subsidies. In relation to this, number 3, the 500,000 yen for companies and 250,000 yen for individuals to support rent expenses. Therefore, 1 million yen for corporation and up to 500,000 yen to individuals. Therefore, about 2 trillion yen of rent support program will be given. So in this way, we are going to give full-fledged support to fixed costs. In the second point on the first page, that is enhancement of financial support centering around MSCs. We are going to provide the unsecured, no-interest loans to SMZ, and also we are going to provide capital participation support and subordinated loans amounting to 140 trillion yen. So financial support will be provided. The third point, we are going to support regional activities. Number 4, we are going to provide various infectious diseases, and we are going to support infectious disease focused hospitals, and the hospitals who are receiving coronavirus patients. We are going to provide a bonus to medical staff and as well, and also we are going to provide emergency comprehensive support grant. On the next page, you can see number 5. Number 1 there, we are going to expand the special allocation for revitalization to cope with the COVID-19 by adding 2 trillion yen. So national government is going to support local municipalities as well. And number 6, contingency funds for the COVID-19. Depending on the changing situations, in order to address the second waves, we are going to give 10 trillion yen of contingency funds. And also others under 5, the agricultural farmers and also education-related people, and we are going to give 636.3 billion yen. And also, we are going to give 96.3 billion yen by transfer to the special account for National Debt Consolidation Fund, and also minus 2 billion yen in terms of reduction in previously approved expenses. On the next page, so how are we going to finance this? And this is the framework we are going to use. On the left-hand side, you can see 31 trillion yen of increase of expenditures, and we are going to issue government bonds. On the right-hand side, you can see. And the original budget for this year and second and first supplementary budget, and 160.3 trillion yen. And also, this 56% is the national bond dependency ratio, and I just limited to the national government's direct spending. However, we are going to increase the private sector assistance and also investment and loan assistance amounting to 171 trillion yen. Therefore, together with the first supplementary budget, the total package will be 234 trillion yen.
Now, I would like to open the floor for questions, and perhaps we should start with those of you who are with us at the conference room. In asking your questions, giving your questions, do state your name and your affiliation before you ask the questions. So, okay, lady in white, please.
Do I speak from here? Hello, I'm with Singapore CNA Channel News Asia. I'm Ichiro Ishida. My question is on your assessment of the situation in the whole of Japan and Tokyo since the lifting of the states of emergency. I believe during the past week, there were around 90 new cases here in Tokyo, including the 13 new that have been announced today. And I think you have been mentioning that you look at 0.5% for 100,000 people when you decided to lift the state of emergency, but it's more than that now. So what do you make of this? And also the situation in Kitakyushu, there's a rising number of cases in Kitakyushu. How do you make of this? So I would like to address this to Dr. Omi and Professor Oshitani. Thank you.
Okay, thank you so much.
Well, thank you for the actually good question. Now, let us recall as to why Japan issued the state of emergency on the 4th of April. There are a couple of reasons, but two major reasons. Number one, the number of the infections was on the rise rapidly. Every day, new cases added. And of course, at that time, total number of cases are not as many as the European counterpart, but the speed at which the increase, the number of cases increased was quite rapid. So we wanted to stem the surge of the infections and bring the epic curve downward. So this is the number one. Of course, we are not entered overshooting, but number of the cases are on the rise so rapidly. So we wanted to bring the curve downward. So this is the number one reason. The second reason, which is maybe more important, first one is important, but maybe more important, just as important, I should say, is that close to the beginning of as of beginning of April, our health system, care system, particularly in Tokyo and big cities, almost reaching the level of collapse. So we wanted to avoid the situation where health system was overwhelmed and collapsed. Now, so that's why the 7th of April, the state of emergency was declared. So purpose was that. Now, so lifting the state of emergency will be made if and when that purpose was fulfilled. Medical care system, as of now, have more rooms to accommodate the infected person because number of cases are dropped. But it doesn't mean our aim was not to reduce the level of infection to zero. It just, given the nature of this virus, it is, at this point of time, impossible to reduce the level of transmission to zero. Now, after the declaration lifted, number of new cases occurred and reported in Tokyo and Fukuoka. This kind of a small surge of the cases were already anticipated. So bottom line is, we like to quickly move to respond to this situation and try to avoid further spread of the disease. So sporadic surge of cases are somehow we anticipated, but of course now Tokyo and Fukuoka, the governors and the people concerned are working very hard to identify the chain of the transmission to try to stem the further spread of the disease.
Sorry. I would like to add a few more words to what Dr. Omi mentioned. We know that there are some more cases in different places in Japan, including Tokyo and Kitakyushu. And we are very much concerned about these situations. And we still we are still closely monitoring the situation in these places. But as Dr. Omi mentioned, this kind of situation could have been anticipated, and the situation is completely different from the situation in the April 7th when we declared the state of emergency. And our capacity is much better, and our preparedness is much better. And in these places, we also are having outbreak in hospital settings, and we have been having the outbreaks in hospital and nursing home type of settings, and where the many elderly people are staying, and so we have to develop more effective intervention to prevent such transmission, especially for the hospital and the nursing home, and we are developing a new strategy to prevent such transmission.
Thank you, Dr. Oshitani. Any further questions from the floor? Yes.
フランスのラジオ局、ラジオ
I am Nishimura from Radio France. I am a French national. Compared to European countries, in Japan, the number of deaths and cases, the reasons for that low number, I want to ask you a question. According to Dr. Omi's explanation, I listened to explanation. However, still there is some mystery as well. In my home country, France, we have a very good access to medical service, and also infectious disease experts are many. So in early stage, quite strict restrictions were taken. But even so, 29,000 deaths have been recorded. Compared to Japan, perhaps France was late in responding to the situation, but maybe that was not the case. Are there any other reasons? Perhaps, according to multiple science papers, I can come up with some hypotheses. For example, Japanese people have a very special genes, perhaps, and also in the past there are coronavirus infectious diseases of other kinds. Perhaps Japanese people had an immunity already, and also virus mutated strains had a maybe larger infectability. Maybe there are other assumptions or hypotheses. Why is it the case that the expert meeting didn't use such hypothesis for your analysis? ありがとうございます。
Even more difficult question. Now, when it comes to the reasons as to why countries in Asia and East Asia are lower than the European, American counterpart, that's the question you are asking. Now, of course, theoretically, a hypothesis can be made to that effect that the hereditary, race, hereditary factors are at play. But to the best of my knowledge, so far, there is no sort of scientific evidence to support that the hereditary factors are really at work to account for the difference between Asia and the European United States in terms of the number of the infectious deaths. Of course, this is the understanding as of today. Who knows? Tomorrow, there's a new scientific evidence to suggest. But at this point of time, at least to I am a public health man. I am not, but to my best of knowledge, I don't think that there's a hard sort of scientific evidence to support that kind of the hypothesis.
日本語でお答えします。
Allow me to speak in Japanese. I think there are various possibilities involved here. We presented to you some data today. We are analyzing data, but what we presented to you is just a part of our analysis or data we are using. There are many other possibilities. However, the biggest reason is that in an early stage, we were able to detect cases, people infected, and also the cluster-based approach that we have been taking were effective to some extent. I think these are the major reasons in our view. Of course, that doesn't rule out any other possibilities or reasons. So I think what you have mentioned cannot be ruled out, cannot be excluded. Therefore, going forward, we are going to bear that in mind in our analysis as well. Because for this particular virus, there are much to be known going forward. Thank you.
Thank you, Dr. Oshitani. Okay, we have Rocky.
Thank you. Can you hear me? Rocky Swift with Reuters. As we kind of go into a new stage in this crisis, more of a chronic, long-term stage, attention is turning towards potential treatments, vaccines, and that like. Can you give us a rundown from your perspective of the Japan-developed drugs, vaccines, trials that are going on now, and when we might see some updates on those clinical trials and those drugs and potential vaccines hitting the market? Thank you.
The number of clinical trials are ongoing, and so some results are coming up, and but it is also quite difficult for us to monitor all different clinical trials, and the many new data are coming every day, and we are hoping that we have some promising the drugs and the vaccines. And the number of researchers in Japan are working very hard on developing the vaccines, the antiviral drugs, and diagnostics. And some diagnostics, some new diagnostic tools are already in use in Japan. But we of course need the pharmaceutical type of the tool, the new drugs, the new vaccines, and without the new tools, our battle with this virus is very difficult, and we are hoping that the new pharmaceutical the tools will come in coming months. We are still not sure when we can have these new tools.
Dr. Omi, do you have anything to add on this one?
I said that clinical trials are ongoing, so we don't know how it takes, but not in the distant future, the result will be made available. Whether these drugs are effective or not effective, we don't know yet, but we have to wait for the final result to be made available.
Okay, thank you. Any more questions from the floor? Yes, please. Gentleman in gray, please.
This is Patrick Welte, Frankfurter Allgemeine Zeitung. I have some specific questions on the cluster approach and two other aspects. On the cluster approach, did you argue that it is only Japan using this retrospective approach in tracing approach, or are there any other countries using this retrospective tracing approach as well? If so, which one would that be? Then you mentioned that 1 out of 4 infected patients don't transmit the infection to other people. Is that a number that is stable over time? Is this a number that only fits into Japan, according to your knowledge, or is it the same ratio in other countries as well? I understand that the cluster approach has a certain limit when there are too many cases. so, and that I understand that was one of the reasons why you started the state of emergency. Can you give a numerical target or some kind of number? When do you have to switch again away from the cluster approach to something else when the numbers are going to rise? And there are two more general questions. There will be some kind of tracing app being introduced in Japan sometimes over the next weeks. What are your expectations to that app? Is it necessary for Japan to do it? Do you need this tracing application on your cell phone? Or what are your expectations on that? And then, Dr. Oshitani-san, you spoke about a new strategy to handle some kind of clusters in hospitals or in other. Can you talk a little bit about that strategy, what you want to do with that?
Okay, thank you so much. Perhaps we can start with Dr. Omi, please, on the retrospective approach as well as the number of 1 to 5 or 1 to 4, whether it applies only to Japan or other countries as well.
That is Oshitani-san's expertise, but generally speaking, I understand. First question related to whether Japan is the only one country which adopted this retrospective. My understanding, Oshitani-san, you have to correct me. Taiwan is one country which uses the similar approach, but based upon the investigation of the policy papers worldwide, I mean, we did not investigate full, but for example, if you look at the policy papers of several European G7 countries, we do not see that any of the countries use this, the retrospective, except Taiwan. You have to correct me. Then second question is, 4 out of 5 do not infect others. That is stable for some time, or it apply only to Japan? That's a very legitimate question. But my understanding is that that is applied to more or less universal. This is the fact. This is the observation. Of course, there are many reasons behind this one. But if you look at the epidemiological data, that's it. That's it. And this is universally observed phenomena. You are correct. Am I correct? Then.
As Dr. Omi explained, we did not check all protocols, but I understand the most the countries are not using the retrospective, the tracing approach, and the number is not the everything. Then the more important thing is the many infected individual do not infect others, and only very small fraction of infected the individuals the pass the virus to others, and that's when the cluster, the big cluster is formed. We are seeing such the big clusters in different settings. So in these settings, many people were infected, considered to be infected from one infected individual. So we believe that this virus cannot be, the transmission of this virus cannot be sustained without cluster. And of course, some secondary transmission can occur in the hospital setting or healthcare settings, but in the community, there also might be some ongoing secondary or third transmission, but the number of infected people from one infected individual should be very small, and so that's why the cluster approach can be applied for this virus, and which is quite different from the influenza or other infectious diseases.
And remaining questions about if so many cases are reported, this cluster-based approach will not work. That's your question, right? You are absolutely right. As the lady from CNN asked a question, mentioned a while ago, one of the reasons, I did not mention all, but one of the other reasons for declaring a state of emergency was to bring the level of the infection to such a level where we can restart cluster approach. That's a 0.5 out of 100,000 population. So if there's so many cases all occurring and reported, it's go beyond the capacity of health workers who deal with the cluster tracing. So you're right. That's why we wanted to bring down the level to the level where we can manage again. We can restart the cluster approach.
Going forward, where is the limit for the cluster approach if we... Going forward, where is the limit for the cluster approach? When do you have to switch back to another approach?
So from the beginning, we consider this the possibility. Our cluster approach started at the end of February, and on 27th of February, we noticed that there were many unlinked cases in Hokkaido, and then we recommend to governor of Hokkaido to take the immediate action, and the governor actually declared their own state of emergency just for Hokkaido, and asked the people stay at home, at least during the weekend. And so that kind of measure, by implementing that kind of measures, they managed to control that outbreak, in the early outbreak in Hokkaido. So we are not just doing a cluster approach. We have to combine the different the public health interventions. One of them is the stay home type of intervention, and we are always combining the different the interventions. And regarding the question about the hospital, the prevention of the transmission in hospital settings, there are several different possibilities, but one of the most important or one of the most difficult challenge in the hospital setting is the many hospital outbreaks or the nursing home outbreaks are triggered by the infected the people who did not show the typical symptom. And we need to detect these cases earlier to prevent the outbreak in these settings. In some places in Japan, they are using the CT scan to screen the pneumonia patient before doing the PCR test. And actually in Kitakyushu, several cases were found by the CT scan before the PCR testing. And as Dr. Omi explained, we are also having new diagnostic tools, including antigen detection test, which can also be applied the whole hospital setting to prevent the further hospital outbreaks or the nursing home outbreaks. And there are many other possible options, but we are considering the different approaches.
Okay, thank you, Dr. Oshitani. Anything to say regarding the new smartphone app, tracing app?
That's also another possible option for the cluster-based approach. And actually, the public health nurses in the public health centers, they have been working very, very hard to identify the clusters. It's quite labor-intensive, the process. But they managed to identify the most of clusters in Japan. By using the new technology, including the mobile app, we may be able to reduce the workload for such contact tracing. And we are trying several the options now.
Okay, thank you, Dr. Oshitani. Any more questions from the floor? If not, I'm already receiving questions from the online viewers. If I may move on to them. The first one is from Mr. Alistair Gale of the Wall Street Journal. His question is related to trains. Have any clusters of coronavirus been found that suggest the virus has been spread on trains? What is your view now on the risk of coronavirus transmission on trains? And what are the most important factors to consider in avoiding virus transmission on trains?
Well, so far we have not confirmed any reported cases whose infection occurred in the train. But given the situation that where people spend several minutes in a very, very overcrowded space, it is possible for the infection to take place in that the setting. Now, we are entering a new phase, and the Japanese society is promoting a new lifestyle, as you may be aware. And this crowded the train is the symbol of Japanese workaholic society, and it does not give the a good project image on the internet. So I think that this is an opportunity for Japan to address this issue of overcrowded train by, first of all, staggered working hours and the remote work. I think that this is we should turn around the situation so that we can, slowly, reduce this Main-Densha, the train full of passengers. I think Japanese society already realized that we have to do something to address this issue.
Anything to add? Anybody else? Okay, well, thank you so much. I have some more questions coming from Isabel Reynolds of Bloomberg. This is about the Diamond Princess. What role did the data obtained from testing Diamond Princess passengers play in your understanding of how the virus spread? And how did it help formulate the Japanese response? What were the most important things learned from the Diamond Princess? And furthermore, who analyzed the Diamond Princess data, and how was it provided to you?
The Diamond Princess data is being analyzed by National Institute of Infectious Disease, and also I understand the Professor Nishimura from Hokkaido University is involved in analyzing the Diamond Princess data. But our cluster approach was drawn not mainly from the Diamond Princess data. Our approach was based on the community data in Japan. And Diamond Princess is too complicated, and the transmission, the pattern, to understand the transmission pattern is very, very difficult for Diamond Princess. And they are still analyzing that. I understand that they are still analyzing the data, and that there are many different possibilities. And but as I said, our approach was mainly based on the community data from the beginning, and we are collecting the data from the different prefectures. And as I mentioned, the public health nurses in the public health centers, they collected high quality data, and that's why we managed to develop this kind of approach.
the next question. This is from Simon Denier of Washington Post. 3 questions, actually. It has emerged that minutes were not taken during meetings of the expert panel. Why was the decision taken not to record minutes?
Well, thank you very much for the question. I think there has been a lot of discussion in various places on this issue. First of all, an expert meeting, there were some kind of records, and it's a kind of choice of this, what kind of records should be prepared according to the nature of meeting, according to the guideline to administer the official documents of the executive branch. And there are 2 categories. One is those meetings which involve decision making. The other is a kind of meeting which do not involve decision making. And according to the judgment, the expert meeting we are talking about belongs to those meetings without decision making. And according to the guideline, detailed minutes, meaning who said what to each of the intervention, those kind of minutes is not really necessary. But instead, we produce some kind of records, what is called the kind of summary of the discussions. And at the first time of the expert meeting, there was a decision made that in order to allow the members of the expert meeting to participate, to discuss freely and candidly, we will not make, we will make a kind of records of summary where without recording exactly who said what. And so I think the records has been made and delivered accordingly up to now. And but at the same time, we have heard there are so because of the importance of discussions, the summary of discussion actually is quite substantive and quite in detail, so that people can understand the content of discussions. So I think the relevant authorities continue to make records in the appropriate way, in such way. Thank you.
The second question coming from Simon Denier, Mr. Simon Denier, is what were the biggest mistakes Japan made in its response to coronavirus, and what has been learned from these mistakes? It's a big question, but Dr. Omi, or?
Well, I think you have to put this overall operation into overall perspective. You know, based upon my experience in dealing with SARS, dealing with the polio, dealing with the H1N1 infection of the 2009, no country's operation is perfect. Different countries has a different history background. Different countries has different human resources basis, technological basis, financial resources. And based upon my own experience working for the international, global health for many years, under this kind of, particularly this kind of very, very difficult situation, I cannot recall that any country's operation is perfect. There are always room for improvement. With the benefit of hindsight, certainly. With the benefit of hindsight, certainly there is room for improvement. And Japan also, there are already some areas that we already acknowledge that for improvement to be made. So if you ask me what is the biggest mistake, it gives the impression that we are full of mistakes and no, nothing to be. I think I like to be fair. There are certainly many areas that we have to improve. So that is a mistake, yes, in a broader sense. And, but there are many things that, as we discussed in the first part of the presentation, there are many areas that, now, areas, I mean, there are many, as if you look at the, our recommendation, our scientific board submitted to the government several days back, they are full of a list of the recommendation that we request the government to implement. So these areas that they have to improve. So many. For example, improve the human resource base of the public health centers. Of course, testing capacity, not only PCR, but antigen detecting. Well, this is a new tool, but we have to also improve. So I think there are many, but you ask one question, so this is my responsibility to answer one, the one point at one point. That is, in Japan, I think two things. As if you compare Taiwan and Korea, fortunately, Japan, we were not hit by SARS. That is one sort of fact. Taiwan, Korea was hit by SARS. MERS, yes. So that alerted the country concerned, alerted. That one, Japan, that is made those countries more alerted. Japan, of course, we are alerted, but in terms of level of preparedness, Taiwan and also the Diamond Cruise event, also gave us a bit of a handicap when we start operation. Many capable staff are drawn into this, and the health system are more or less, some of the hospital occupied with if the person who are infected so these are the challenges that we face. So certainly one of the things that Japan, with retrospectively, there's a fact that we did not, we are not hit by SARS is the sort of one of the major sort of difference. This is a historic fact that made a little bit of our approach different from the Taiwan and the Korea. That's a fact.
And as Dr. Omi mentioned, the every country has some strengths and weakness, and Japan also has some the strengths and the weakness. And we have to remember that we are now dealing with the previously unknown virus. So the COVID-19 is quite different from SARS in terms of epidemiology. And nobody still knows the answer how to deal with this virus. And we've been learning a lot in the past 4 months. And the world has been learning a lot of things in the past 4 months. But there are still many unknowns. And every country have been making some mistakes. And the important thing is how to minimize the impact from these mistakes. And we are also changing our policies and changing our strategies. And that was necessary for this kind of virus. They're always necessary for this kind of virus. Nobody knew the answer at the beginning. And there's still nobody know the best answer for this virus.
Thank you, Dr. OSHITANI. And the final question from Mr. Simon Denier is actually addressed to Dr. OSHITANI once again. Dr. OSHITANI, you told NHK in March the testing centers were not being set up quickly enough. Do you think Japan now has adequate testing and tracing capacity to cope with possible new outbreak of COVID-19?
I think this issue was already answered. This question was already answered by Dr. Omi, and it was true that at certain point of time, the PCR capacity in Japan, there was the fully stretched. Because of the rapidly increasing number of cases, in some places, especially at the end of March and early April. But the PCR capacity, after that, the PCR capacity was expanded. And in the early stage, I believe that we had enough the PCR capacity to test not all, but most of the severe cases. And we also have the enough PCR capacity to investigate all the clusters, and which they gave us the enough data to analyze the clusters. But as I mentioned, it was true that at a certain point of time, the PCR capacity was fully stretched. But we also need to remember that it is not easy to expand PCR capacity. We are very cautious to expand the PCR capacity because the quality assurance for the PCR testing is quite important. And that's why there was some delay and there are some other reasons, but the main reason was we have to make sure that the high quality testing was done in all the testing, the laboratories. And
Anything you'd like to add, Dr. Omi?
To add what Dr. Oshitani said, I think as I mentioned in my earlier presentation, actually this testing is something that the international community is very much interested in. Now, this issue can be looked at from two different perspectives. Now, one perspective is seen from the viewpoint of the general public, we, citizens. The second perspective is seen from the viewpoint of the overall sort of public health. Now, if you look at this issue from the individual citizen's perspective, at early stage of the outbreak, we are able to provide enough sort of a testing. But as Dr. Oshitani mentioned, closer to the beginning of the April, so many cases, then our policy, Japan's policy has been such that we should be able to provide a test who need to be tested based upon the judgment of doctors. That is our policy. But as the number of cases really increase, closer to the beginning of April, as I said in my earlier presentation, it was not able to provide, tests for those people because of the number of cases on the rise. So at that time, really, the citizens feel frustrated because government policy is that those people who are judged by doctors to be tested should be tested, but that there was a gap between what we promote and what has been done. So this is this is the dilemma. That's what happened. But now, given the lessons we learned, Japan society still a lot of room for improvement, but capacity has been increasing. For example, as of the 24th of May, Japan total 3,291 tests has been done nationwide, and 35,291 tests was done in the week of, up to the week, for 1 week to the 24th of May. and 243 were tested positive. So number of tests was really now. So of course, if the wave of the cases are really coming now, again we may be stretched. That's why Japanese government is working hard to improve the capacity, strengthen the capacity of not only PCR, but antigen detecting the rapid diagnosis test. This has to be go in parallel. Then, if you look at the overall sort of more public health perspective, as I mentioned, as of now, Japan's, I will not repeat because I said that already, overall performance is not so out of the acceptable range, as I said. But again, I'd like to emphasize again that as of April, if you look at the issue, people may say, okay, maybe Japan's performance from the global health perspective is okay, satisfactory, but that is a different, if you look at the issue from the citizens' point of view, no matter how good the Japan performed in the international global health picture, every citizen has a sort of has not access to the test. This is the area that we have to improve. That's why we acknowledge, government has acknowledged. That's why Japanese government is working very hard. Of course, the speed is not as sufficient as people may accept, but still there are a lot of effort being made. So I hope that this kind of situation will further improve with the help of the antigen detecting rapid diagnostic kit as well as the PCR.
I forgot to tell the two more important things. The one is the safety. We have to protect the healthcare personnel who are collecting the samples. At that time, at the end of March, the shortage of PPE, personal protective equipment, was a major issue. And there was a very severe shortage of masks and gowns and so on. And we also did not have enough trained personnel who could collect the samples. So the safety was also the major issue that need to be considered to expand the PCR capacity. Then another thing is we have a policy to isolate, at that time, they isolate all confirmed cases in hospital. And at the end of February, the hospital beds are already occupied with many, many patients. And if we expand the PCR capacity, the hospital was fully stretched at that time. And if we test more cases and we have more positives, and we might add some more burden to these fully stretched hospitals. And there are several other reasons, but these are the main reasons that we are very cautious in expanding the PCR capacity in Japan.
Thank you, Dr. OSHITANI. We have a final question coming from the online viewers. This is about travel restrictions. What are your recommendations for lifting travel restrictions? What are the criteria to choose, and what are the countries that would come first or already safe to lift restrictions? Secondly, on the same topic, Japan has introduced travel restrictions for long-term visa holders in Japan. They can leave, but in difference to Japanese, basically cannot re-enter. What is the medical reason for that Japanese citizen of Japan can re-enter and foreign residents of Japan cannot re-enter? This is partly not a medical question, so I should just start by saying that it's a bit too early to say what Japan will be doing in terms of travel restrictions. Of course, we're currently concentrating on controlling the spread of the virus in Japan. And of course, we also have to see what's happening around the world in other countries as well. and whether it would be right for Japan to actually open the doors for people to come into Japan, or vice versa as well. At some point in the future, we should be able to inform you what the status of this matter is, but at this point, I think it would be a bit too early to say. I think the question is, from the medical point of view, whether the restrictions make sense or not, what needs to be done. Do you have anything to say, Dr. Omi or Dr. Oshitani?
According to the information that I got today, there are some visitors from overseas. Either I don't know the nationality, it's Japanese, but at least some people coming from overseas tested positive, and the positive rate is on the rise. I don't know how much, but so it's an indication that as of today, introduction of virus into this country is still ongoing. So that makes sense for the country to maintain to some degree of the border control. Now, question is whether we should continue to close the border forever. Well, I don't think so. Sooner or later, I don't know how soon, we have to open. Then, on what basis we open? I think we have to monitor very closely the level of the transmission of the countries, our countries, either through WHO, international organization, or bilaterally. We have to monitor. And if the level of transmission of those countries are more or less under control, it's a time for us to reopen the border. That is a principle in the medical.
I hope this answers your question. That was actually from Mr. Martin Kurling of Handelsblatt. So I think we're running out of time, but if you have any further questions from the floor in this room? Okay, yes, please.
Sorry, Patrick Welter, once again, Frankfurter Allgemeine Zeitung. I have two short questions. One is concerning this immigration issue. If you are Japanese leaving the country, Japan lets you come back in when you want to go back to Japan, even at this time. If people living in Japan, paying taxes in Japan, leave the country, they are not allowed to come back to the country. So is there any medical reason why Japanese are allowed back in and foreigners are not allowed back in? And the second question, this is to Oshitani-san. Thinking about the cluster approach, it seems to me at the beginning of the whole exercise, you recognized that there were some limits of PCR testing and other stuff, because Japan might not have been as prepared as, let's say, Taiwan or Korea. If you would have had another chance at the beginning, would you have gone for the cluster approach, or would you have done something different?
Okay, thank you so much. So I guess these will be the final two questions. The first one on the travel restrictions. I believe it will depend on the country that you wish to travel to. You know about the 100 or so countries that have been designated as level 3 in terms of virus transmission. And if these are the countries that you intend to travel to, I think, as Dr. Omi mentioned, certain precautions need to be taken. Otherwise, maybe not so. But in any case, we have to look at what's happening in other places. If it's a humanitarian situation, we will look into the cases one by one. But we are advising our citizens, Japanese citizens as well, not to travel to these countries in case they are included amongst the 100 or so countries. Dr. Oshitani, for the second question.
The prospective tracing approach is usually used to contain the virus, contain the infectious disease. And from the beginning, we believed that this virus is not containable. This is very difficult virus to contain. And because there are many the mild cases or even asymptomatic cases, the cases without symptoms. And the containment is very, very difficult. So that's why we believe that the different approach is necessary for this virus. And the cluster approach may not be the only solution for this virus, but we need to also explore other possibilities. But at the moment, this approach, actually, we call it the dispersion rate, only the small fraction of cases they infect others. So this is one of the few weak point of this virus. And that's why we are using this strategy. And so we still need to explore other possibilities, but this is one of the possible solutions for this virus.
Well, to add to what Dr. Oshitani said, the retrospective versus prospective. I think if I share this one, maybe you have a better understanding of what we are talking about. Now, as I said very briefly in my earlier presentation, prospective approach is the approach that was used in the time of SARS. You remember, I'm sure. Now, why? This is in stark contrast with the COVID-19. In the case of SARS, if the majority of the cases develop the symptoms, then, of course, there are close contact. Then we follow close contact. Then if the close contact develop, they will not infect others. Infected person do not infect others until the disease develop. This is the difference. This is the biggest difference between SARS and Corona-19. SARS, even if I'm infected, I will not infect others until I develop the symptoms. That's why in the case of SARS, you follow the close contact, and when and if close contact develop any symptom, fever, cough, etc., then that's the time they are quarantined. That's how. So if you compare these two, in terms of complexity of the strategy, SARS is simpler. That's why, SARS, starting with January, or depending upon how you define, starting January 2003, already July, that is 6 months later, the disease was contained because of the nature of the virus. But this one, as Dr. Oshitani said, there are many asymptomatic cases. That gave us a lot of difficult challenges.
Thank you, Dr. Oshitani and Dr. Omi. I'm afraid time has run out. Some of you may have some more questions, but maybe we will be providing this opportunity from time to time. So maybe next time you can ask the questions. But thank you for listening today once again. And I would like to thank all the experts, including Dr. Omi and Dr. Oshitani, for their wonderful presentations and answers today. Thank you, everybody, and I would like to conclude this conference. Thank you. Thank you so much.